Okay. Thank you, Natalia, for inviting me here in Moscow, which is a wonderful place. Actually, I've been here more than 10 years ago. It's changed dramatically. It really improved. And of giving me the opportunity of talking about what happened in the last, I would say, couple of decades, because what you requested to me is something that came out from the big studies that have been performed in our field. What have we learned during those last decades? We have learned a number of things that I believe are extremely important, just because that now we have a very coherent and very sound indication of how to deal with glaucoma in our clinical practice. First of all, we have been taught that in glaucoma, when we talk about diagnosis, we have always to think about structure and function. We cannot think of thinking only about function or only about structure, because the two issues are strictly related. So when we talk about the glaucoma continuum, as you see this rainbow that has been developed by Bob Wyreb some years ago, you see that there is some sort of progressive changes that starts, of course, at the level of the structure, at the level of the retinal fiber layer, but then the visual field becomes the most important diagnostic tool in order to monitor our patient. And when we talk about glaucoma, I want you to keep in mind that glaucoma is probably the worst disease in our field, because it can lead to irreversible blindness, which is much worse than the hypovision that we get with macular degeneration. So, during those decades, we had this number of studies that have led to the validation of a number of concepts that are today the standard of our practice. So what have we learned and should translate in practice? First of all, we learned that in order to treat our patient, we need to effectively reduce the IOP. And it has been developed the concept of target IOP to be reached during the monitoring of our patient. What is the basis of this concept? The advanced glaucoma intervention study clearly showed that during the follow-up of 7 years, only those patients that had an IOP that was always, that was always below 18 millimeters of mercury could avoid a real significant progression of the disease, as compared to those who instead had reached this level only seldom during the follow-up. The same holds true for the collaborative initial glaucoma treatment study, where the two arms that were compared, treated versus not treated, actually needed to reach a certain target IOP. And actually, with those level of IOP reduction, 37% with the medical treatment, 46% with the surgery, the number of patients that progressed was extremely, extremely low. The same worked out in the collaborative normal tissue glaucoma study. Also, in those kind of patients, by effectively decreasing IOP, it was possible to reduce the incidence of progression. And interestingly, if you look at all those studies that have been performed, only those which had a threshold of target IOP to be reached during the study helped us to reduce the number of progressive patients. Where those concepts was not introduced, such as in the GPS or in the EMGT, the number of progressive patients was much, much higher. Talking about effectiveness in reducing IOP, we have to deal a little bit with medical therapy. And you probably know that until 15 years ago, we were used to use the beta blockers. Actually, there were some studies that tried to address whether the use of beta blockers was useful in the prevention of progression of glaucoma, and actually none of them could really validate the use of beta blockers. So with this meta-analysis that was performed by the group in Milan that I was working with, was the basis after which all those studies that I've just shown started. And interestingly, those negative results were confirmed by the betaxolol study that was performed in London, where there was no difference between the active treatment and the placebo in terms of reduction of incidence of glaucoma. In the EGPS, where there was almost no difference between the dorzolamide and the placebo, and there was actually not significant difference in terms of incidence of the disease in the two arms, as you can see in this figure. The first trial where it was possible to see that active medication could really prevent the progression, significantly prevent progression, was the United Kingdom Glaucoma Treatment Study, where the investigators used the prostaglandin, latanoprost, compared with placebo. And of course, this induced a very clear difference in IOP reduction between the two arms, and it was possible to detect a clinically significant difference in terms of cumulative proportion of patients that were developing a progression in glaucoma. And in fact, during these couple of decades, the introduction of PGs has really changed our way of treating our patient, because all the PGs that you can see here, bimatoprost, travoprost, latanoprost, have a clearly higher efficacy than as compared to timolol and of course to all the other drugs. And the only one that is midway may be tafulprost, which has shown a greater efficacy as compared to timolol, but not really that much. What else have we learned? We have learned that trabeculoplasty, whether it is ALT or SLT, has a limited efficacy. That doesn't mean that it doesn't work, but simply that we cannot expect that much. I wanted to summarize the results on the trabeculoplasty, showing you the graph from the ages, where you can see that there is no, excuse me, Natalia. Okay. But it doesn't work. Okay. Using an ALT as first procedure after the medical treatment, at 5 years, you can expect at least 50% of patients that are doing well, which is actually what we see in our daily practice. We can say that the laser can be compared to a single active treatment. What else? We have learned how to deal with risk factors, how important they are. The most important risk factor for open-angle glaucoma is pseudoexfoliation. Today we will talk a lot about pseudoexfoliation. The EMGT showed that there is a huge difference between those patients with pseudoexfoliation compared with those patients who don't have pseudoexfoliation. The number of patients who are progressing having pseudoexfoliation is much larger than those who are progressing without pseudoexfoliation. And of course, other predictive factors are really relevant. The more advanced is the disease, the higher is the likelihood to develop a progression of the disease. The older is the age, the higher is the likelihood to develop a progression of the disease. And of course, the higher is IOP, the higher is the likelihood to develop a progression of the disease. And most important, in the MGT, they showed the famous magic number that for each single millimeter of mercury of IOP reduction from baseline, you may predict a 10% reduction in the risk of progression from the initial of the follow-up to the end of the follow-up. So actually each single millimeter of mercury may count. What else? We have learned how important is the rate of progression. It was quite clear from the EMGT the difference in rate of progression between the treated arm, where the mean deviation change was minus 1.8 decibel for 5 years, as compared to the not treated arm, where the MD change was minus 3 decibel per 5 years. And this means that we may really assess the rate of progression of our patient, which means that with the help of dedicated software, such as the one that we have, that has been implemented in the Humphrey visual field examination, we can really look at this important factor, and we can use this factor, the rate of progression, when we decide whether the target IOP during the follow-up of the patient deserves to be changed or not. We learn how important are the antimetabolites. I mean, I'm sure that all of you who are performing glaucoma surgery know that a filtering surgery cannot be performed without the help of mitomycin C or 5-FU. It has been clearly shown that the patient operated of trabeculectomy with mitomycin have a much higher likelihood to preserve their visual function over time as compared to those who don't have who had not the help of mitomycin C. So the IOP is much better controlled and then the visual function is much better controlled. Quality of life. Quality of life has become quite important. Of course, we live in wealthy countries where population expectations are very high. Quality of life is very important. First of all, because the medical treatment is often associated with a lot of secondary effects that patients don't want to have, and also surgery may be affected by secondary complication, which may really be dangerous for the patient. So the idea of keeping a good quality of life in this patient is very important. For instance, not treating patients who do not deserve to be treated is extremely important, because in that case you can really preserve the quality of life of these individuals. And another very, very important issue, at least to me, that came out in the last years, is how important is the clear lens extraction for angle closure glaucoma. I know that Dr. Tan will talk about that, but I want just to mention this very crucial study, that is the EAGLE study, compare the primary phacoemulsification versus laser iridotomy, okay? In order to see whether was more effective phacoemulsification alone or laser iridotomy. And actually, looking at very well-selected patients where the disease was extremely clear and excluding those where it was preferable not to do it, excuse me. They showed that by phacoemulsification, it was possible to achieve lower pressure as compared to iridotomy. And you could do this almost clearing the patients by their own medication as compared to the patients who were treated with laser iridotomy, actually who in the majority were obliged to hold the medication that we were using before. So, which are the parameters for appropriate management of our glaucoma patients? First of all, we have to think to individualize the therapy, because each patient is different from another patient. Second, we need to select a target IOP depending on those parameters that we know, the stage of the disease, the IOP at baseline, and so on. We have to think about the quality of life, because we may have systemic and local side effects from drug therapy. And we need to give to our patient an acceptable therapeutic regimen that can be kept for all the life. We need the patients to be compliant, otherwise the treatment will not work. And we should not be afraid of surgery, because surgery has to be done whenever necessary, of course with the appropriate technique. Let's move on to the other group of patients that we are interested in, which are the patients with ocular hypertension, which are not really patients. They are normal individuals with normal visual field, normal optic disc, with absolutely perfect sight. They have just an IOP which is repeatedly measured above the level of 21. And this subject has been exhaustively explored by two big studies, the OATS first and the GPS after a while. One performed in the States, the other one performed in Europe. And it's interesting to see what they got. From the OATS, we have learned that the efficacy of IOP reduction is important in preventing or in delaying the onset of glaucoma. In fact, by achieving at least a 20% IOP reduction during the follow-up of 5 years, it was possible to make a clear difference between those who were treated from those who were not treated, okay? As you can see from this figure. The GPS could not really see the difference between the dorzolamide and the placebo, but In a retrospective analysis, it was possible to see that also in the GPS, for each single millimeter of IOP reduction from baseline, it was possible to reduce the risk of developing glaucoma by about 10%. So this figure confirms the number that has been found in glaucoma patients in the early manifest glaucoma trial. Another issue that we have learned from these two studies that for sure it is unnecessary to treat all our ocular hypertensive individuals. In the OATS, after 5 years, about 10% of those patients who were not treated developed initial sign of glaucoma, very initial sign of glaucoma. Okay? In the EGPS, after 5 years, between 10-15% had the same outcome. So this means that for 5 years, at least 85-90% of these individuals will not develop glaucoma if they are not treated. So thanks to the OATS and the GPS, we learned how important it is to perform a predictive factor analysis. This helps to estimate the individual risk of developing glaucoma over time and to obtain a practical indication to decide whether to treat or not our patients. Interestingly, as you can see here, the predictive factors found in the two studies were exactly the same. And in most cases, the hazard ratios were really the same. And this helped us in joining the two studies and in producing a prediction model that could be really helpful in our daily practice using 5 parameters which are very easy to be achieved: age, IOP at baseline, central cornea thickness, vertical capitis ratio that we can describe at the slit lamp, and the pattern standard deviation of the Humphrey visual field. And just using a calculator like this, it is possible to estimate the risk of each single patient to develop glaucoma over a follow-up of 5 years. The OATS 2, that is the second part of the OATS 1. In this second part of the study, the investigators decided to treat all of the patients. The gray line in the middle shows the time during which all the patients were put on treatment. Well, what have we learned from this part of the OATS? First, we've learned that delaying the treatment, so starting treatment 6 years after, doesn't mean anything in terms of ability to reduce the incidence of glaucoma. So we can delay the treatment because actually the figures that we achieve by treatment are the same that we can achieve starting the treatment at the very beginning. Second, using the risk, the individual risk calculated by means of that calculator, it was possible to see that those patients that had a risk lower than 6% actually didn't show any difference between those who were treated from those who were not treated. So maybe that for this lower range of risk, we can foresee just a monitoring of the patient without starting a treatment from the very initial part of the follow-up. Of course, those patients with a very high risk, above 13%, the risk to develop glaucoma was quite high, and I believe that this group of patients should be treated from the very beginning. Probably the mid group, those whose risk is between 6 and 13%, may be managed differently, just discussing with the patient whether they prefer to be treated or not, because anyway, the risk to have a significant visual change over time is still very low. And in fact, the conclusions of these studies were very well addressed by the final sentence of the investigators that show that clearly say for those patients, we have to think about life expectancy and to discuss everything with the patient and decide with them whether it's good or not to start the treatment. The last issue that we learned from these studies is the use of imaging. In this study, we use the HRT. HRT now is is not sold anymore. But the OCT has well replaced the HRT. Both the oaths and the GPS has shown that those patients who had an abnormal HRT examination at the beginning of the study had a higher risk to develop glaucoma over time. This holds true for the Murphy's regression analysis in the oaths, the Murphy's regression analysis in the GPS, and if we compare all the parameters in the two studies were really the same. This means that this kind of examination may really be helpful in detecting those patients who may have a higher risk to develop glaucoma. So what are the parameters for appropriate management of ocular hypertension patients? We know that medical treatment for ocular hypertension reduces the incidence of glaucoma. It's very clear. But we also have seen that the individual risk for glaucoma is highly variable and can be accurately estimated. So when should we start the treatment? There is not a common way to decide where it is, but we have to think about the fact that those with the lower treatment may probably deserve to be just monitored over time and not treated from the very beginning. And last but not least, remember that the delay of treatment of ocular hypertension does not induce an increase of glaucoma incidence over time. So in conclusion, knowing, correctly interpreting, and translating in daily practice the results of randomized clinical trials is not easy because you have to read the papers very well, or you need to listen to people who can really translate for you these results. But it's advisable and viable, and should be the most professional and conscious background of our daily clinical practice. So our practice should be really based on what the evidence has shown to us, and this evidence should be professionally used every day. I would like to thank you for this, and thank you again, Talia, for inviting me.